All right, let's dive right into this explainer and explore what I honestly consider the ultimate medical whodunit. We're going to investigate exactly how the brain is starved of its absolute primary fuel, how the body aggressively fights back, and how medical professionals piece together the clues to finally corner the culprit. Because when blood sugar drops, the stakes are incredibly high, and the physiological drama that unfolds is, well, it's nothing short of fascinating.
To really understand this mystery, we first have to establish the victim of our story, and that is the brain. Your brain is a total fuel hog. It demands a constant, uninterrupted supply of glucose. When that supply drops, we're not just talking about feeling a little tired, it's a direct, severe assault on the central nervous system. Without glucose, you experience neuroglycopenic symptoms. The brain literally begins to shut down, leading to confusion, sudden behavioral changes, seizures, and, if left unchecked, far worse. It's a true medical emergency.
So, here is our roadmap for the investigation. First, Whipple's triad. Second, the fortress defense. Third, the sabotage known as HAF. Fourth, the usual suspects. Fifth, the insulinoma interrogation. And finally, the verdict and cure.
Section 1. Whipple's Triad, Establishing the Ground Rules.
To confirm the brain is actually under attack and we're not just dealing with a false alarm, clinicians rely on Whipple's triad. You absolutely have to document these three exact steps. First, the patient must actually be experiencing symptoms of hypoglycemia. Second, you need a confirmed low plasma glucose measurement. And third, those symptoms have to resolve the minute the patient's glucose levels are raised back to normal. If you get a low blood sugar reading but there are no symptoms, or if the symptoms stick around after the sugar comes back up, you're barking up the wrong tree and have to look elsewhere. Now, here is a critical clinical pearl. Handheld finger prick glucometers and continuous monitors are fantastic for everyday diabetes management, sure, but they are notoriously fleeky at the absolute bottom of the range. Plus, phenomena like a super high white blood cell count can actually consume the glucose in a blood sample right after it's drawn, giving you a completely fake low. That's exactly why a proper, rapid laboratory blood draw is absolutely mandatory to lock in step 2 of Whipple's triad.
Section 2. The Fortress Defense, the body's alarm system.
Think of the body's counter-regulatory hierarchy like a 5-tier physical fortress. The absolute first line of defense, the second glucose even barely dips, is simply turning off the insulin. If that fails, defense number 2 fires. The pancreas secretes glucagon to tell the liver to pump out stored sugar. Still dropping? Defense 3 kicks in, epinephrine or adrenaline. This is what causes your heart to just pound and your hands to shake. Defense 4 is a delayed hormonal backup. And finally, defense 5 is behavioral. The autonomic alarms ringing throughout your body make you feel overwhelmingly hungry, literally forcing you to eat and manually save the day. But we have to bust a massive misconception here regarding cortisol and growth hormone. It's so widely believed that they rush in to save you during a sudden crash. They don't. These hormones take a really long time to mobilize. Actually, they only act if the hypoglycemic attack drags on for over 4 hours. In a sudden, acute crash where seconds and minutes matter, they provide exactly zero help. Your immediate survival rests entirely on glucagon, epinephrine, and your own behavioral response. Section 3. The sabotage, also known as HAF, the fortress breached. Sometimes, it's an inside job. It's a tragic complication called HAAF, or hypoglycemia-associated autonomic failure. And it works like this. If you suffer a severe low blood sugar event, your body essentially resets its own alarm thresholds. A recent crash actively sabotages the body's ability to trigger the epinephrine alarm for the next crash. Your body just gets used to the lower levels, which means the next time your glucose plummets, your nervous system simply stays completely quiet. This specific sabotage branches into 2 distinct, highly dangerous failures. First is defective counterregulation. Because the epinephrine response is muted, your liver never gets the signal to release emergency glucose. Missing that physical defense literally skyrockets your risk of severe hypoglycemia by 25 times. Compare that with hypoglycemia unawareness. In this scenario, because there's no adrenaline rush, you don't get the sweating, the palpitations, or the tremors. You get absolutely no warning symptoms, meaning your behavioral defense of eating is entirely lost, which multiplies your risk by 6. It's a really vicious, silent cycle. But here's the incredible twist in our story. 2 to 3. That's the number. HAAF is completely reversible, and it only takes 2 to 3 weeks of strict, scrupulous hypoglycemia avoidance to successfully reverse it and restore those crucial autonomic alarms. Just by keeping blood sugar safely elevated for a few weeks, the nervous system completely resets its thresholds back to normal, and the fortress is rebuilt.
Section 4. The usual suspects, the DICE-H lineup. Clinicians actually use a great mnemonic to categorize the suspects. DICE-H. D is for drugs, and these are by far the most common culprits, especially exogenous insulin and secretagogues, which are pills like sulfonylureas that basically force the pancreas to pump out insulin. I is for critical illnesses, things like severe liver or kidney failure. C stands for cortisol or hormone deficiencies. E is for endogenous hyperinsulinism, meaning the body is making way too much of its own insulin. And H stands for hereditary or inborn errors of metabolism. But when the medical detective arrives at the scene, they are always going to interrogate that drug suspect first.
Now, alcohol is a completely fascinating suspect from that lineup. Imagine someone goes on a several-day binge with very little food. Their liver's storage of ready-to-use glycogen gets totally depleted. The body normally steps in by making new glucose from scratch, a process called gluconeogenesis. But alcohol actively blocks the liver from making new glucose. So once those glycogen reserves run dry, the alcohol is literally preventing the liver from creating a lifeline, leaving the starving brain completely defenseless.
Section 5. The insulinoma interrogation, the smoking gun. To really crack this case, we have to look for the smoking gun, which is a chemical fingerprint called C-peptide. When your own pancreas naturally makes insulin, it packages it with a byproduct. That's the C-peptide. If a patient is secretly injecting pharmaceutical insulin to fake an illness, their blood will show sky-high insulin but suppressed C-peptide. Why? Because the injected stuff doesn't have it, and their own pancreas has basically gone to sleep. But if they have an insulinoma, which is a rare insulin-secreting tumor inside the pancreas, both their insulin and C-peptide will be inappropriately elevated despite their crashing blood sugar. Finding that C-peptide is absolute, undeniable proof of endogenous or internal production.
To capture this crime in action, doctors initiate what is basically a dramatic stakeout, a 72-hour fast protocol. The patient is admitted and closely supervised. The detective waits, repeatedly measuring insulin, C-peptide, and glucose. The stakeout only ends when the glucose drops to a dangerous level, specifically below 45 milligrams per deciliter. At that exact moment, if the insulin and C-peptide are still pumping high, they've caught the tumor red-handed. Finally, they give an IV push of glucagon. If the blood sugar violently spikes, it definitively proves that endogenous hyperinsulinism was the culprit holding the glucose hostage.
Section 6. The verdict and cure, closing the case.
Closing the case always requires a two-pronged approach. First up is urgent treatment. If a patient is completely unconscious, the immediate rescue action is a fast IV push of glucose, or an emergency intramuscular injection of glucagon to force the liver to dump its stores. But remember, that just buys time. The second prong is long-term prevention. Depending on our culprit, this might mean surgically removing that insulinoma tumor, which is almost always entirely curative, or meticulously altering the doses of diabetes medications to prevent the crashes from ever happening in the first place. But beware of a totally fascinating plot twist right at the end of our urgent treatment protocols. Emergency glucagon injections? They are completely useless for alcohol-induced crashes or prolonged starvation. Think about it. Glucagon works strictly by telling the liver to release its stored glycogen. If those reserves are already empty from a multi-day binge, you can pump in all the glucagon you want, the liver has absolutely nothing left to give. IV glucose is the only physical rescue there. And that brings us to the ultimate, universal truth of managing this condition. Medical treatments like IV glucose or glucagon shots are always transient. They're just a temporary chemical bridge. The real, ultimate physiological reset requires one simple thing. You must urge the patient to eat. Only by consuming actual carbohydrates can the body replete those vital glycogen stores and truly rebuild its internal fortress against the next attack.
We've tracked the suspects, we've analyzed the sabotaged fortress, and we've found the cure. But this whole medical mystery leaves us with something pretty profound to ponder about our own physiology. Do you know the signs of your body's alarm system? And what would you do if, one day, it just suddenly went completely silent? Think about that incredible internal fortress working around the clock to keep your brain fueled. I really hope you found this explainer as fascinating to dive into as I did to put together. Until next time, keep exploring the incredible mysteries of the human body.